Okay, let's dive right into this. Welcome to today's Explainer, everyone. Today, we're taking a really close look at one of the most influential, heavily debated, and frankly consequential books in modern medicine, the DSM-5. Whether you're working in healthcare, studying psychology, or honestly just fascinated by how we map the human mind, we're going to break down the exact anatomy of psychiatry's ultimate authority manual. We'll look at the massive 2013 update, the recent text revisions, and the ongoing scientific debates surrounding exactly how we define mental health.
Here is the roadmap for our explainer today. We'll start with understanding the DSM-5, then move into the evolution of the manual, structure and organization, the clinical diagnostic process, advantages of standardization, and finally, criticisms and limitations.
All right, Section 1, Understanding the DSM-5. So the absolute crucial point here is that the DSM-5 is a standardized classification manual used by mental health pros everywhere. Published by the American Psychiatric Association back in 2013. It doesn't just list out names of conditions. It actually provides the exact diagnostic criteria, super detailed symptom descriptions, duration requirements, severity levels, specifiers, and vital guidance for differential diagnosis. Basically, it creates a shared, standardized terminology for everything from depression and anxiety to schizophrenia, bipolar disorder, and PTSD.
But to really appreciate this tool, we kind of have to understand the massive problem it solves. Just imagine looking at disorganized, handwritten medical records from old psychiatric institutions decades ago, long before a standardized system existed. Mental illnesses were described wildly inconsistently from one hospital to the next. The DSM was born out of a desperate need for a common language. With this standardized framework, researchers know for sure they're studying the same conditions. Clinicians can reliably talk to each other, and healthcare systems can properly document and fund treatment plans.
Moving right along to Section 2, Evolution of the Manual.
Let's see how this thing evolved, because it's an actively living document that has completely changed over the decades. Back in 1952, post-war America saw the release of DSM-1, which had about 100 disorders and was heavily influenced by psychoanalytic thinking. Then we got the expanded DSM-2 in 1968, but 1980 was the real game changer with the DSM-3. This version revolutionized the field by introducing operational criteria and a multi-axial system which massively improved diagnostic reliability as researchers started using structured interviews. Fast forward through ongoing revisions, the DSM-3R in '87, the evidence-based expansions of the DSM-4 in '94, and its text relation in 2000, until finally, committees reviewing thousands of research papers gave us the DSM-5 in 2013. And fun fact, it was the first to use an Arabic numeral instead of a Roman numeral. Most recently, in 2022, we got the DSM-5-TR, a text revision that also included a really extensive ethno-racial equity and inclusion review.
Next up, Section 3, Structure and Organization.
Now, if you are familiar with the older DSM-4, you probably remember the multi-axial system. It used to separate clinical disorders, personality disorders, medical conditions, and psychosocial factors into distinct axes. Well, the DSM-5 completely dissolved that into a streamlined non-axial system. Now, all primary diagnoses are just listed together sequentially right there in Section 2. To give you a sense of scale, they're grouped into broad categories like neurodevelopmental disorders, schizophrenia spectrum disorders, bipolar, depressive, anxiety, obsessive-compulsive, trauma-related, eating disorders, and personality disorders. Meanwhile, Section 3 is kept separate for emerging measures and conditions that still require further study.
And as science evolves, the diagnoses have to evolve too. In 2013, we saw some huge reconceptualizations based on contemporary research. For example, Asperger's syndrome was merged into the broader autism spectrum disorder. Gender identity disorder was completely renamed and reconceptualized as gender dysphoria. Previous subtypes of schizophrenia were just eliminated entirely, and they also removed the bereavement exclusion, which used to prevent a diagnosis of major depressive disorder shortly after the death of a loved one, basically acknowledging that severe depression can absolutely co-occur with natural grief.
And this brilliantly illustrates how the manual is constantly adapting. The 2022 text revision didn't just update the explanatory text, it brought in brand new diagnostic categories based on a decade of fresh data. It introduced unspecified mood disorder and stimulant-induced mild neurocognitive disorder. Plus, it added vital behavioral symptom codes to help clinicians accurately report suicidal behavior and non-suicidal self-injury, making absolutely sure those critical risk factors aren't overlooked, even if they don't neatly fit into a primary diagnosis.
But maybe the most talked about addition in 2022 was prolonged grief disorder. So why was it added?
Well, research showed that between 4% and 10% of bereaved individuals experience this intense, persistent yearning for the deceased, emotional numbness, and severe functional impairment lasting more than a full year after a loss. Recognizing that specific 4 to 10% prevalence was huge. It allowed the psychiatric community to officially differentiate pathological, prolonged grief from normal mourning, ensuring those individuals can finally get targeted interventions.
All right, Section 4, Clinical Diagnostic Process.
Let's put this into practice. Imagine a fictional patient comes into a clinic presenting with persistent sadness, sleep disturbance, profound fatigue, and a total loss of interest in daily life. The clinician doesn't just open the book and start ticking boxes. Step 1 is a comprehensive clinical interview. Step 2 involves diving into their medical, psychological, family, and social history. Step 3 is a formal mental status examination. Then, in Step 4, the clinician carefully compares what they're seeing with the diagnostic criteria in Section 2. Crucially, in Step 5, they literally have to rule out medical conditions, medication side effects, or substance use that might actually be causing those symptoms. Only then, in Step 6, do they determine if full diagnostic criteria are met. Step 7 is assessing the severity and adding any specifiers, which all finally leads to Step 8, developing a highly individualized treatment plan.
I really want to pause here for a second because this is absolutely vital. The DSM-5 supports, but absolutely does not replace, professional clinical judgment. It's a complex decision tree, not just a simple checklist. Getting a diagnosis requires a professional assessment of the whole person, integrating clinical expertise with that patient's unique cultural and social context.
Moving to Section 5, Advantages of Standardization.
The benefits of having this standardized system are profound, which is exactly why the DSM-5 is practically universal in the US. First off, it provides incredible diagnostic reliability. That means a psychiatrist in New York and a social worker in California are speaking the exact same language when discussing a patient's care. It enables researchers around the globe to study mental health consistently, it gives educators a structured way to train new clinicians, and honestly, it provides the strict documentation necessary for insurance and healthcare systems to actually function and fund treatments.
And that brings us to Section 6, Criticisms and Limitations.
Now, what's really interesting about this is that an authoritative tool of this magnitude naturally invites some rigorous, evidence-based pushback. Critics, and honestly even the APA itself, have noted that inter-rater reliability can still be surprisingly low for certain disorders, like generalized anxiety. There are also ongoing debates about potential financial conflicts of interest with the pharmaceutical industry. Anthropologists and cognitive scientists have argued that the manual leans a bit too heavily on Western-centric norms, sometimes missing the mark on cultural diversity. And perhaps the biggest, most prominent concern is the risk of overdiagnosis, the fear that expanding these criteria might end up pathologizing totally normal human distress.
To look at that last point objectively, consider this statement from the British Psychological Society in response to the DSM-5. They expressed deep concern over the, quote, continuous medicalization of their natural and normal responses to their experiences. Their argument here is that by applying rigid diagnostic frameworks, we might just be categorizing normal individual variation as an illness. And in doing so, we might be overlooking the fact that psychosocial factors, things like poverty, unemployment, or trauma, are often the actual root causes of a person's distress, rather than some internal, categorized pathology.
And taking a neuroscientific perspective, we have this fascinating quote from Dr. Thomas Insel, the former director of the National Institute of Mental Health. Back in 2013, he noted that while the DSM is highly reliable as a dictionary, ensuring everyone uses the exact same terms in the same ways, its weakness is its lack of biological validity. See, the DSM-5 primarily classifies disorders based on observed behavioral symptoms, not on biological underpinnings, genetics, or objective lab tests.
Because of this underlying tension between observed behaviors and actual biology, alternative frameworks are actively being developed as we speak. For instance, the NIM launched the Research Domain Criteria, or RDoC project. Rather than just starting with clinical symptoms, RDoC attempts to integrate modern neuroscience, genetics, and biology into psychiatric diagnosis right from the ground up. While it's currently more of a complementary tool used for research, it represents a massive shift in how we might classify mental health down the road. Which leaves us with a truly compelling thought to end our explainer today. As neuroscience continues to evolve and we map the brain with unprecedented precision, will future diagnostic manuals abandon these behavioral categories entirely in favor of strict biological and genetic markers?
Or will the human experience always require a manual that accounts for the behavioral, social, and emotional context of our lives? It's a pretty fascinating question to ponder. Thank you so much for joining me on this deep dive into the DSM-5, and as always, keep